No, ma'am.
Good evening all. I welcome you for the Tnfog Marathon CME, which is conducted every month on second Friday. So we have the theme on every month. This month we have the theme as, since December was 8th day, we had it as HIV and PID. Usually we have 3 sessions, one UA session, one update, and one panel. After the sessions, the questions will be asked, and to encourage the delegates, the prizes will be given for the person first who answers. Similarly, in the UA session, the 2 UAs will be talking, and the best orator will be awarded in the Tnfog annual conference. The judge will be the same judge throughout the year. Now, this is the aim of our Tnfog Marathon CME. Now, I hand over the mic to Dr. Radhika Gauri. Radhika, you can proceed. Ramani madam is in one meeting, so she may not be able to join.
Good evening, everybody. Thank you, Sampath ma'am, for this wonderful program. So this is the Tnfog Marathon CME, and on 13th December, we are going to start the program now. First is Tamil Thai Valthu. We have the lamp lighting. So welcome address by Sampath ma'am.
Ramani madam is not there. I will give the welcome address. No problem. Okay, thank you, Radhika. I welcome you all for the Tnfog Academic Marathon CME, and I welcome Dr. Rajendra Singh Pardesi sir for accepting to be the chief guest, and Dr. Vidya Topi for accepting to be the guest of honor for our program. And we have the 2 judges, always permanent judges throughout the year, Dr. Shanti and Dr. Kartika Prabhu. And we have 2 UAs to give the talk, Dr. Archana and Dr. Ashika. And I welcome Dr. Anjalakshi, past president of Tnfog, being the chairperson, and Dr. Anjisoni, who will talk on HIV update. And we have the panel moderated by Dr. Gayatri and Dr. Murugalakshmi, with wonderful panelists, Dr. Usha, Dr. Gayatri, Dr. Kokila Devi, Dr. Swati, and Dr. Uma Brinda. And I welcome our MOC, Dr. Radhika Gauri, and we will start with the session. Sahiti, you can put Pardesi sir, TV. Welcome, sir.
Thank you, thank you.
Rajendra Singh Pardesi is Dr. 28 papers he has presented in national and international conference, 7 times the best paper awardee in FOXI AACOG, and he was a faculty in AOCOG 2011 and Thai and AOCOG 2013 Bangkok, and he was a faculty at FIGO, Kuala Lumpur and Rome, and he was chairperson of Food and Drug Committee 2012 to 14, and he has got the Best Committee Award, and he was Vice President Foxy from 2019 to 20, and Vice President Amox 2018 to 20, and the President Amox 22 to 24. And of all things, he is a good advisor. With his advice only, we have also started our Tamil Nadu Federation. Thank you, sir. I welcome you and bless
Thank you, Dr. Sampath Kumari, for kind introduction. Good afternoon, everybody. Respected Dr. Ramani Devi, President Tnfog, Dr. Sampath Kumari, Secretary Tnfog, Dr. Sarvana Kumar, Treasurer, and our guest of honor and my close friend, Dr. Vidya Thobi. She is the VP-elect of FOXI. Dr. Anju Soni, Dr. Anja Lakshmi Chandrasekhar, past President of Tnfog, and friends. I am really feeling proud to be a part of this Tnfog program. Tnfog Marathon CME. Tnfog is really close to my heart. We did many webinars in last 2 years associated with Tnfog when I was president of AMOX for 2 years. Dr. Ramani Devi and Dr. Sampath Kumari, they are the stalwarts of FOXI and Tnfog also. And we are working together since long in FOXI. And this webinar is mainly focused on HIV and PID, these topics which still are a major concern with women's health. And with the galaxy of speakers, chairpersons and panelists like Dr. Asika, Dr. Archana, Dr. Karthika, Dr. Sripriya, Dr. Radhika, Gauri, Dr. Usha, Dr. Gayatriyan, Dr. Gayatri S, Dr. Swati, Dr. Uma, Dr. Shanti. I think this is going to be a great event. And I'm really happy that they involved Yuva, like Dr. Ashika and all other Yuva in this webinar. They are promoting Yuvas. So I wish very success to Dr. Sampath Kumari for our future endeavor FOXI. As president of FOXI, she will be contesting in future.
Yes, sir.
And wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you so much, sir. We will also expecting you in incoming years as president of FOXI. Yes, sir. Thank you so much, sir. Next, can we have the CV of Dr. Vidya Thobi? Yes, as Pathogenesis sir was telling, we did lot of programs combined with AMOX when he was the president. With all committees, almost we have done the programs. Anyway, we should continue working with him. Amma Sakiti, Vidya Thobi CV kodu. Yes, my dear friend Dr. Vidya. So incoming Vice President elect in FOXI, and she was President of Kasoga 2023 and State Advisory PCP and the Board Karnataka, Chairperson of Food and Drug Committee. As Rajendra Singh sir was telling, both of them are friends and both of them got the Best Committee Award from 2015 to 2020, and ICOG Governing Council Member, FOXI Champion Award, National Corresponding Editor Joki, Organizing Chairperson for all the Kasoga programs. So twice she conducted the conference, I think, in Bijapur once.
Yeah.
President of Bijapur Society 2009, and she has many publications to her credit. And she is the master of nutrition and food and drugs. Okay, now I welcome Dr. Vidya, and thanks for accepting us as guest of honor. And I like to wish
thank you, dear Dr. Sampath Kumari, who is a dynamic secretary of TNFOG, I must say. Thank you, Dr. Ramani Devi, who is also very close to my heart, who is a president of TNFOG, and of course, Dr. Rajendra Singh Pardesi, who was past president AMOX, as well as he was my vice president also. So there are two vice presidents under whom I have worked, Dr. Ramani as well as Dr. Rajendra Singh Pardesi, and really they have groomed me to this stage. And of course, Dr. Sampath was always there for my support. So I wish her also for her future endeavors all the best. And second thing I must tell that TNFOG Marathon CME, not only CMEs, I am looking after her all programs. And as Dr. Sampath stepped in as a secretary of TNFOG, Tnfog has made its name, not only in the webinars, but all the Foxy programs. Tnfog is a very prominent place. Now, Sampath and our all South societies, we had done 3 days program also. And that was very much success. Now we will do it again once more. And today's program, I must say, there is a UA session. There are they have covered even classification, pathogenesis, and even diagnosis of HIV as well as pelvic inflammatory disease. I must say that pelvic inflammatory disease, to diagnose and to treat, is very much, it requires lot of skill. Skill means you have to diagnose it correctly, and many times the organisms are not isolated, and we are always treating them symptomatically. And many times the patient, they take very incomplete treatment, and the consequences of this pelvic inflammatory disease, like infertility and other, even heavy menstrual bleeding, all these consequences are many. So in the panel discussion, I'm definitely sure that they will be considering these aspects, and they are discussing the panel on pelvic inflammatory disease. I must appreciate that they have called Dr. Anju Soni, who was a chairperson, as well as she's co-vice president with me. So she will be mainly talking on HIV diseases and its consequences. I really thank for the opportunity. All the best to Sampath as well as everyone who is participating. I cannot take everybody's name, but all the best. I pay my respects to Anjalakshi madam, who is very senior, and always I look forward for her guidance in my tenure. Thank you very much, Sampath, Dr. Ramani in her absentia, and all the senior Tnfog leaders who have participated. Of course, all others are my very good friends from Tnfog. Thank you very much.
Thank you, Vidya. Thank you, Rajendra Singh sir and Dr. Vidya for attending this, accepting to be the chief guest and guest of honor. Thank you. We'll go to the scientific section. Radhika Gauri, you can introduce the chairperson of the UA session. Radhika, unmute. Radhika Gauri, you are mute.
Yes, ma'am. Thank you, Sampath ma'am. Thank you, Rajendra Pardeshi sir and Vidya Tobi ma'am. Now we'll proceed on to the UA session. I invite Dr. Shanti ma'am, who is a professor of Savita Medical College and Hospital, Chennai, for the UA session as judges. And she's from Madras Medical College, has done her MDOG from IOG. And she's trained in ultrasound, obs and gynae, advanced infertility and laparoscopy. She's also provided an instructor course, and she's got 25 plus publications, and her field of interest is endoscopy, high-risk pregnancies, and adolescent gynecology. And she's also an examiner for undergraduates and postgraduates. And she's an invited faculty in conferences, and she's organized national and international conferences. Welcome, ma'am. I also invite Dr. Kartika Prabhu, ma'am, who is a professor in SRM Medical College Hospital, Poteri. And she has done her MBBS from MMC and MD from JIPMER, and undergraduate and postgraduate teacher. Her special interest is in high-risk pregnancy, gynae endoscopy, and midlife health. And she's got many awards. Dr. Asha Baxi Award in Annual Conference, RCOG, 2016. And paper presentation, UA Foxy South 2011, DIPSI 2013. And she's won a gold medal in SRM 2020, and also she's got the AL Mudalia Traveling Fellowship, and she is a faculty in national regional conferences, has more than 20 national and international publications. I welcome Dr. Kartika Prabhu. Ma'am, would you like to introduce Dr. Archana Balaji? Dr. Shanti, ma'am?
Yes. Good evening, one and all. So it's my pleasure to be a part of this regular webinars. So in this session, I take pleasure in inviting Dr. Archana Balaji, who has done her MBBS in Stanley Medical College, Chennai, and her MSOG in KPV Government Medical College, Trichy. And she has had FMAS in World Laparoscopy Hospital at Delhi. And she's a consultant obstetrician gynecologist in Athi Nursing Home, Beam Nagar, Trichy. And her areas of interest are laparoscopic surgery and infertility, and has presented papers in various national forums. Over to you, Dr. Archana.
Thank you, ma'am. Thank you for this wonderful introduction. Good evening, one and all. I thank Dr. Ramani ma'am and Dr. Shanta ma'am for providing this opportunity to present in this wonderful webinar session. And it is a great pride in presenting in front of Dr. Rajendra sir, Dr. Vidya ma'am, and eminent judges. So today my topic is on the etiopathogenesis and diagnosis of the HIV. Etiology. So HIV is a non-transforming human retrovirus. It belongs to Lentiviridae family, and we have two subgroups, HIV-1 and HIV-2. HIV-1 is common in US and Central Africa, and HIV-2 is seen in West Africa and India. The structure of the HIV is very important because it changes its structure now and then. So it is very critical, crucial for us to for the treatment part. So this is spherical and it contains electron dense and cone shaped core surrounded by lipid envelope derived by the host cell membranes. So the viral core contains many proteins, of which the most important one is major capsid protein P24. This is uniquely this is diagnosed. This is very important because it helps in the diagnosis, and it's the protein that is used in the ELISA method detection. And the nucleocapsid protein P7 and P19, and also has the viral core also has two copies of viral RNA and three viral enzymes: protease, reverse transcriptase, and integrase. And the core is surrounded by a matrix protein P17, and the envelope was studded with bullet-shaped glycoproteins, that is GP120 and GP41. This is general structure of the HIV, showing the bullet-shaped GP120 and 41. Next. The HIV-1 RNA genome, it contains gag, pole, and envelope genes, which are very typical of the retrovirus, and they're very crucial because this causes the viral replication. These genes are very important for the viral replication. Next. Next. Coming to the pathogenesis of the HIV infection, the major target of the this virus is the immune system and the central nervous system. This causes the death of the CD4 cells and the impairment of the T helper cells and the infection of the macrophages. The life cycle of the HIV consists of 7 stages. It causes binding, fusion, and the reverse transcription, integration, replication, assembly, and budding of the new viral genome within the CD4 helper cells. The life cycle of the HIV, it mainly infects the cells by using the CD4 molecule as the receptor. So the initial step is mainly involves the GP120 envelope glycoprotein to the CD4. It causes the conformational changes, and it results in the GP41 membrane penetration and causes membrane fusion and entry of viral genome into the human cell cytoplasm. This causes the viral entry into the CD4 cells. Next step is the replication. It causes, so the RNA genome of the virus, it undergoes the reverse transcription and synthesis of the double-stranded complementary DNA. This integration of the provirus into the host cell genome plays a major role because it determines the latent period of the whole infection. Alternately, it can also be transcribed, leading to the formation of the complete viral particles, which bud from the cell membranes, leading to the viremia. So there will be rapid progression of the disease. If the virus is released, there will be productive infection and extensive viral blooding, leading to the death of the infected cells. So this causes the T cell depletion. This loss of infected CD4 cells is mainly because it causes the direct cytopathic effects of the replicating virus. It causes the lysis of the T cells and causes lymphopenia, and there will be altered T cell function. It this again it causes the increased B cell activation, causing polyclonal B cell activation, and the whole immune system is altered. There will be alteration in monocytes and also the macrophage function. Coming to the CNS involvement, it is called the HIV-associated neurocognitive disorder. It is HAN. In this, the neurons are not infected. It is the microglial cells that the virus gets infected, and the microglial cells releases the soluble factors like interleukins, tumor necrotic factors, which are the main culprits of the CNS involvement. So, this is the mRNA change which causes the glial degradation. So the mode of transmission is mainly by the sexual transmission, which is 75%, and the risk of transmission to the sexual route is very minimal. That is 1% per coitus. But in blood transfusion, the risk of transmission is very maximum. That is up to 90 to 95%, and it was also transmitted through the injected drug abuse and needle stick exposure. So diagnosis is mainly because as early as we diagnose, as early as we start the treatment, the disease transmission can be prevented. There, in this HIV, there is mainly 3 stages: the acute, chronic, and the crisis, causing weight loss, fever, rash, cervical adenopathy, and vomiting. In this, the level of HIV RNA in the blood will be is the powerful marker of the HIV disease progression. In this acute phase, there will be rapid increase. Excuse me, don't forward the slides. 1 minute. Yes. There will be rapid increase in the CD4 count cells, and then again after 3 months, there will be decline in the cells. After this, there will be a latent period in which the viral gets that provirus get formed and get integrated within the host cells. After many years, that is 8 to 10 years, the patient will be in the chronic phase, and then after 10 years, due to the extreme depletion of the CD4 cells, the patient goes into for crisis, which is defined as the acquired immunodeficiency virus, that is after 10 years. This diagnosis is very important because for the treatment and the transmission, the CDC classification categories of the HIV infection are as 3 categories. There is asymptomatic, that is acute HIV virus, or persistent generalized lymphadenopathy. It is based on the CD4 T cell counts. The first group is more than 500 cells, and the second is more than 200 to 499, and third is less than 200. If it is symptomatic, it comes under B, B1, B2, and B3, again based on the CD4 cells. And the third category is the C, which includes the opportunistic infection, neurological disease, and the tumors. Next. So the diagnosis is mainly based on these 4 tests, that is the antibody test, antigen antibody test, nucleic acid test, and enzyme-linked immunosorbate assay. This antibody test, it is the most common test and includes most rapid test and home use self-test, because it detects the HIV antibodies, that is mainly the anti-envelope antibody, anti-P4 antibodies, and these antibodies are more specific for the HIV. It can be detected as early as 23 days to 90 days. The second one is the antigen antibody testing. It detects both HIV antibodies and also the HIV antigens in the blood. It is most commonly used test that it can, the detection window period is 18 to 45 days. This nucleic acid test is very specific and looks for the viruses in the blood. It can detect the blood as early as, this nucleic acid test are very early. It can detect the HIV infection very early as 10 days. In enzyme-linked immunosorbent assay, also known as the Western blot, these detects the antibodies antibodies, that is the Western blot antibodies of HIV-1 and 2. Next. So routinely in pregnancy, we consider this HIV screening as an opt-out technique because it is highly effective. Opt-out test, it is used for the generalized screening, and we need not get the consent for the patient for this test because due to the increased risk of transmission, this test is as opt-out test because it removes the stigma associated with the HIV testing, and it can detect the diagnose the disease earlier, and also for the early treatment. It reduces the risk of the transmission, and also it is cost effective. So these are the window period of the different tests, of which the nucleic acid test is very early in detection rate, but it is quite costly. But the commonly routine that rapid antigen antibody self test, it can detect up from 18 days to 90 days. So next is the HIV and the pregnancy. Usually during the routine screening, we need to screen this HIV infection. If the patient is found to be positive, if the patient is positive, we should confirm that samples sending to the higher centers and also by the NAT test, and we should link them to the ART centers. If the patient is already known HIV positive on ART, we should continue the ART treatment. We should also do the other test for the well-being of the mother, which includes serum creatinine, hemogram, and bacteriuria screening. The main important test in pregnancy is the HIV RNA quantification to determine the viral load, and also the CD4 lymphocyte count and retroviral resistant testing. We should also evaluate the hepatic aminotransferase level and other opportunistic infections like cytomegalovirus, toxoplasmosis, hepatitis C serology screening, and tuberculosis skin testing, purified protein derivative, or interferon gamma assay. And we also evaluate the need for pneumococcal vaccine, hepatitis B vaccine, hepatitis A vaccine, Tdap, and influenza vaccine for that patient. We should determine it according to the viral load. Next, coming to the treatment, depending upon the various actions where it acts, it is having mainly the 4 classification: nucleoside reverse transcriptase, protease inhibitor, non-nucleoside reverse transcriptase inhibitors, and integrase inhibitors, of which the routine is that routine first line ART is 2 nucleoside reverse transcriptase enzyme and 1 non-nucleoside reverse transcriptase enzyme, which is usually the tenofovir and lamivudine and efavirenz. Next. So, if the CD4 count is more than 350 in the pregnant patients, we need to start an azothiodine monotherapy. And if the CD4 count...
Sorry for interrupting.
Just 2 minutes, ma'am. Just come. Just 2 minutes.
Okay.
If it is less than 350, we should start on tenofovir and lamivudine. So, the self-testing, HIV self-testing plays a major role in the detection because we need to do the post-test counseling because it takes both the medical and psychosocial aspects. We should clearly differentiate the patient. We should counsel them properly. We should have a clear distinction between the HIV and the AIDS. And this early initiation of the ART will clearly reduce the viral load and prevents the horizontal transmission to the HIV partners and also the vertical transmission to the children. So this December 2024, it is the December 1st World's AIDS Day. The theme is Take the Right Path. because if we diagnose early, we can prevent the transmission, which is very, very important. And the goal is that of the WHO is that to reduce the transmission to 0% by 2030. So let us take join hands with them, and we need to detect early for this zero transmission rate of HIV. Thank you. Thank you so much.
Thank you, Archana, for your elaborate question. So actually, you told about testing for the mother. Suppose mother is positive, how will you test for the newborn? What test you use?
The mother is positive, we need to start, even if the newborn, like we need to start the antiviral intrapartumly by giving the zidovudin IV transmission.
How will you look for, how will you diagnose HIV infection in the newborn?
By nucleic acid test, ma'am. NAT test, because it detects the like HIV as early as very early.
Can you use a routine antibody testing for a newborn?
No, ma'am, because the antibody takes some time to develop in the newly infected HIV mother.
It is not like that. From the mother, antibodies will already cross to the fetus. So the test which we do cannot detect. So it will take some time for the antibody to be produced in the newborn. So you have to look for the PCR test, polymerase chain reaction test, to diagnose HIV infection in the newborn.
Okay, thank you.
It was a wonderful presentation, Dr. Archana. But certain things I would like to reiterate. Like you forgot to mention about the co-receptor, right? CCR5. And when the virus infects the cells, CD4 cells, it needs a co-receptor. Okay, CCR5 and CHCR4. Okay, so that is one thing. And when you mentioned in the slide, you mentioned about all the modes of transmission, but forgot to mention about the mother-to-child transmission. You were telling about the sexual transmission and all those stuff. So you talk much about the pregnancy, but that was not mentioned. And I just wanted to clarify, what is opt-out test? What did you mean about it?
Opt-out test is there are two tests, like opt-in and opt-out. Opt-in is the patient consent is needed, whereas an opt-out test, the consent is not needed. It's if the patient denies, like regarding the consent part, like the patient, the consent is not needed for the test to be done.
Is that so, or the patient? It is the patient's right to choose not to get investigated. The patient can refuse.
The patient can refuse, ma'am, but like
only with consent, I think you can. You are supposed to do any kind of test, right?
Yes.
So you need to be clear about that, right? If the patient denies in the first visit, you have to counsel her later on and again ask her to get it tested.
Yes.
Okay. So that's fine. Otherwise, it was a wonderful presentation. Okay. Thank you.
Thank you, ma'am.
Thank you, Archana. Thank you, Dr. Archana. Next is Dr. Ashika. I invite Dr. Karthika Prabhu, ma'am, to introduce Dr. Ashika.
Dr. Ashika has done her post-graduation from JIPMA. She has done MRCOG, and she also has got fellowship from European Board of College of Obstetrics and Gynecology. She has received Dr. A.V. Umachigal Memorial Award in JIPMA, and she has also got Yuva Icon Award. And she is a joint secretary for IME Tirunelveli. She is a member of FOXY, British Medical and Fetal Medicine Society, and she's also a member of IAGE and Indian Menopause Society. Over to Dr. Ashika. She'll be talking about etiopathogenesis and classification of pelvic inflammatory disease.
Good evening. Thanks for the kind introduction, ma'am. Thank you, Dr. Ramani Devi, madam, and Dr. Sampath Kumari, madam, for this opportunity. It's an honor to present in the Tnfog Marathon CME. And today I'm going to talk on PID, which is... Yes. So my topic today is on pelvic inflammatory disease, the pathogenesis and classification. Pelvic inflammatory disease, we are going to see about the definition, pathogenesis, followed by the classification. So what is pelvic inflammatory disease? It's an infection and inflammation of the upper genital tract of the women, which involves the uterus, the fallopian tubes, and the ovaries. It's a broad spectrum of inflammatory process. It ranges from endometritis to salpingitis to pelvic peritonitis and then to tubo-ovarian abscess. So it's a broad spectrum which encompasses all these conditions. So the incidence of PID, according to the Center of Disease Control, it's estimated to be 1 million each year, and in India the incidence in reproductive age group women is 24 to 32%, and 3.6% of the women will experience one episode of PID in their lifetime, and the lifetime prevalence on the whole is 4.4%. And why are we worried about PID? Because the sequelae of PID is very severe, and it has got a long lasting consequence in the patient in forms of infertility, chronic pelvic pain, or ectopic pregnancy. And any patient who gets a PID will have a sequelae. It is about 1 in 4 patients who have been infected with PID will develop a sequelae. And coming to the tubal factor infertility, when there is one episode of PID, the tubal factor infertility incidence is around 11.4%, which increases to almost 54.3% when there are 3 or more episodes of PID. And the incidence of ectopic pregnancy in mild to moderate PID ranges from 15% to almost 50% in cases of severe PID. Coming on to the pathogenesis of PID, whenever there is a disease, we need to have a host who is susceptible or who has got the risk factors. So when there is a susceptible host followed by the disease causing organism, it results in the disease process. So what are all the natural defenses which we have in our body to counteract this disease process starts from the vagina. So the vagina has got lactobacilli, which produces lactic acid, which maintains the pH between 3.8 to 4.5, which has got the bactericidal actions, like it inhibits the adherence of bacteria to the vaginal epithelium. And there is also excess production of hydrogen peroxide, which is going to inhibit the growth of bacteria, and the estrogen, which facilitates the growth of lactobacillus. So all these are the defense mechanism at the outset. So moving on to the cervix. Cervix has got the cervical mucus. It has got a bacteriostatic effect. The antibodies and inflammatory cells which are present in the cervical mucus is going to act as a competitive inhibitor for the bacteria which are going to colonize the cervix. So whatever organism ascends to the cervix, it gets stopped at the cervical mucus because of all these characteristics and the antibodies and inflammatory cells. So then the bacteria has to ascend to the endometrium. Endometrium might have some commensals, but usually there is no bacteriological medium. There may be normal genital flora, but it is bacteriologically sterile. So what happens to these defense mechanisms in PID is when there is a risk factor, as in the form of vaginal douching, which is going to reduce the concentration of lactobacillus, or excess use of antibiotic therapy, which decreases the lactobacillus, the first line of defense gets compromised. And then coming to the cervix, in at the time of menstruation and sexual intercourse and endocervicitis, the cervical mucus gets altered, and this results in ascent of the organisms from the vagina to the endometrium. So this is how the PID sets in. So what are all the organisms? So the PID is caused by many microbes, so it is always polymicrobial. So that is why we always treat it as a polymicrobial treatment. We use combination of drugs for the treatment. So the most common are the Neisseria and chlamydia, and the Mycoplasma hominis and Mycoplasma genitalium, Trichomonas vaginalis. And the last two organisms, the Actinomyces and Mycobacterium, are always associated with chronic pelvic inflammatory disease. And the endogenous agent, aerobic or facultative, the Streptococcus, Staphylococcus, Haemophilus, and Escherichia coli, they are all there in the flora, but they cause infections or an inflammation when there is instrumentation or when there is any breach of the defenses like menstruation, or if there is any retained products. All these are going to cause. And anaerobes, which include bacteroids, peptococcus, peptostreptococcus, and clostridium. So coming on to the, so based on this polymicrobial etiology of PID, the treatment has been devised. So always we should include the drugs which takes care of Neisseria as well as chlamydia as well as the anaerobes. So always it is a combination of drugs. So either it is ceftriaxone, doxycycline and metronidazole, or clindamycin and gentamicin, and or it could be levo or moxifloxacin with metronidazole. So what is the pathophysiology? So Neisseria gonorrhea and Chlamydia trachomatis are the two important organisms. We'll see how it causes PID. Almost 15% of the women who are having infection with Neisseria will develop PID. The complement mediated inflammatory response. Neisseria causes direct inflammatory response of the endometrium. So there is migration of the leukocytes, transudation of the plasma into the tissues, and damage to the ciliated cells of the fallopian tube, which causes cell death and tissue damage, and the fibroblasts, which replace the dead cells and cause scarring, and it causes tubal adhesions and alter tubal motility. Coming on to chlamydia, out of the 30% of the women who have chlamydia infection will develop PID. It is an obligate intracellular parasite. It affects the columnar epithelial cells, which is there in the endocervix, and the tissue destruction is mainly a cell mediated immunity. So once the chlamydia infection has been set in, it triggers an autoimmune response because of its homologous sharing of protein between the heat shock protein, which is there in the humans, and the chlamydial 57 kilodalton A protein. So because of this, it causes an autoimmune response which results in severe damage, which tells why 30% of the women with chlamydia will develop PID. And then coming on to the pathologic changes in the epithelial surface of the fallopian tube, this is the normal tubal epithelia, which has got a wonderful cilia, which is going to transport the ovum. But once there is PID, this is the surface of the cilia, which is seen on the electron microscopy. So we can see that there is a selective loss of ciliated epithelium, and which is going to alter the intratubal ovum transport, which results in the devastating sequelae of PID, which is tubal infertility and ectopic pregnancy. This explains the entire destruction of the ciliary epithelium. So basically, it starts with cervicitis in high-risk women whenever there is an endocervical mucus breach. It causes ascending infection, the ascent of the lower reproductive tract pathogens into the endometrium, causing endometritis, followed, which is going to be a direct inflammatory response in cases of Neisseria, and cell-mediated immune response in cases of chlamydia, and it results in salpingitis because of the destruction of tubal epithelium. Some goes on to oophorytis and tubo-ovarian complex and the tubo-ovarian abscess. Tubo-ovarian complex is when we can see that the ovary is distinct from the tube, and the abscess is when there is no demarcation and there is collection, so, and resulting into peritonitis. So this is the pathogenesis of entire PID. What is the clinical presentation? Most of the time, pelvic inflammatory disease, it is asymptomatic. If there are symptoms, it could be lower abdominal pain, deep dyspareunia, which is of recent onset, and an abnormal uterine bleeding. All this because of the endocervicitis, which results in a postcoital bleeding or an intramenstrual bleeding, and a menorrhagia due to endometritis. There can be abnormal, which is characteristic mucopurulent discharge from the cervix and the vagina, or the patient might present even with fever. So there are certain criteria from the CDC, which has defined as minimum criteria, which is cervical motion tenderness or uterine tenderness or adnexal tenderness, and the additional criteria to support the diagnosis of PID. which is oral temperature more than 38.3, abnormal cervical mucopurulent discharge, presence of WBCs on saline microscopy of the vaginal fluid, elevated erythrocyte sedimentation rate, elevated CRP, and laboratory documentation with NAT of cervical infection with Neisseria or chlamydia. And specific criteria. This specific criteria, which we usually don't need any criteria to diagnose PID. These are when we suspect a PID and we have a minimum criteria, we can go ahead with empirical treatment of PID. And the specific criteria is just to increase the specificity, the endometrial biopsy with histopathologic evidence of endometritis, TVS and MRI showing thickened fluid filled tubes with or without free fluid, or tubovarian complex, or Doppler studies indicating pelvic infection, and laparoscopic findings consistent with PID. So this is a very clinical presentation of the pelvic inflammatory disease. Sometimes the patient might not present with any symptoms as well. So coming on to the classification. Now going on to the classification of PID, in various guidelines we see various classifications of PID, which I will try to list out the few important classifications, which is the primary or PID or secondary PID, or a subclinical PID, acute and chronic, and uncomplicated and complicated PID, mild, moderate, or severe PID. So depending on the mode of spread, we can classify the pelvic inflammatory disease into primary or secondary. Primary is when the infection occurs as a result of a typical pathway, like it is a sexually transmitted infection by chlamydia or Neisseria. So it is a primary PID. And the secondary PID is because of the infections which is there in the adjacent structure, and it has traveled on to the tubes. For example, in case of the primary pathogen is elsewhere, not in the genital tract. For example, it is in the colonic, in case of appendicitis and Crohn's disease, and genitourinary atypical infection and infected endometriomas.
Sorry to
Or
interrupt.
sometimes,
2 more minutes,
yes, ma'am.
Ashika.
Yes, symptoms, depending on the symptoms and duration, there can be subclinical PID where the patient will not have any symptoms. Acute PID is when we call the patient has PID but the symptoms are less than 30 days. Usually it is because of one of the cervical pathogens or enteric or respiratory pathogens. Chronic PID is when the PID symptoms last longer than 30 days. It is typically which is caused by actinomyces and Mycobacterium tuberculosis. So the subclinical PID is where the patient will not have any symptoms of PID. She usually presents with infertility, and on laparoscopy or HSG we might see a bilateral tubal disease. So there is no history of PID, and the laparoscopy is going to tell us that there are some additions or hydrosalpinx, and antibodies can even be demonstrated to chlamydia and Neisseria, and the microscopy will show typical features of destruction of the tubal epithelium. And depending on the presence of complications, which we mean only the tubo-ovarian abscess. So complicated PID is in the presence of tubo-ovarian abscess, and complicated PID is no tubo-ovarian abscess. So it's usually mostly used in the guidelines from the European Society on one of the French guidelines. And depending on the severity of the symptoms, it could be either mild to moderate PID, where there is clinically no evidence of sepsis, patient is hemodynamically stable, pain is well controlled with simple analgesia, and we have all clinical features of pelvic inflammatory disease, and there is no evidence of tubo-ovarian abscess on ultrasound. Usually they are managed as an outpatient. Severe PID is when there are presence of signs of sepsis and tubo-ovarian abscess. Basically these patients will require only inpatient management. Most of the time the patients which we admit as inpatient, in conditions such as surgical emergencies cannot be excluded in the presence of TIVO abscess, pregnancy, severe illness, nausea and vomiting and fever, unable to follow or tolerate a oral regimen, and no clinical response to oral antimicrobial therapy. So coming on to the last, which is the staging of the PID. This has been, it is a very old staging of PID, 2001. Why it was introduced? Because of the to report to the US FDA regarding the data collection. They have actually classified it into 4 stages, where stage 1 includes only who do not have overt peritonitis, only the symptoms of PID, and the second will involve pelvic peritonitis. Stage 3 is demonstration of tubo-ovarian complex, and stage 4 is with women with ruptured tubo-ovarian abscess. This currently is not, we don't use it clinically, but it is just for data collection back in 2001, which was used by the US FDA for to see the efficacy of the antimicrobials which are used in PID. So these are my references. Thank you.
Very good presentation, Ashika. You have covered in depth the various
Thank you.
classifications and etiopathogenesis.
Thank you, ma'am.
Can you tell how vaginal douching, whether it is harmful or beneficial? For
No,
some
ma'am.
people, they give vaginal douching when they suspect infection, whether it is harmful or beneficial.
No, ma'am, it's definitely harmful because it is going to alter the lactobacillus. So whenever the lactobacillus concentration is going to come down, it is going to change the pH, which will result in ascent of the normal commensals into the endometrium. So it's definitely not going to be beneficial.
So
Which
it will
we need.
also affect the cervical
Cervical mucus, yeah.
and,
The consistency of the cervical mucus gets altered because of the douching. So which is an important barrier in the pathogenesis of PID.
good presentation.
Thank you.
Good presentation. So which infection
you.
causes more damage? Like,
Chlamydial, ma'am, because of the autoimmune response. Because even one episode of chlamydia, it just comes and goes away, but the autoimmune response, which is triggered by it because of our sharing with the chlamydial protein, it's going to be there for a longer period. This causes severe PID.
okay. So what about tuberculosis?
Yeah, tuberculosis is our common, most common cause of PID in our country. But once we diagnose tuberculosis, the management is going to be anti-tuberculous treatment, which we need to explain the patient as well. So in
Yeah,
our
how to
scenario,
diagnose,
it is in our scenario, it is the most common cause, one
yeah,
of the
how to
most common.
diagnose, that is the most
It is going to be a paucibacillary TB. We cannot, we can start empirically if we see signs of PID pointing towards tuberculosis. I think we can go ahead with anti-tuberculous treatment because we are not going to get TB PCR positive in the sample. It is because it is paucibacillary.
So anything about mycoplasma?
Myco
Mycoplasma.
Yes, mycoplasma is actually it's recently been in the picture for the pathogenesis of PID because of the antibodies which are produced in the against the mycoplasma has been detected. Most of the time, we are not able to isolate the organisms from the culture. So it is, but when we just monitor the patient serially, she might develop an antibody to mycoplasma. So that is why in PID, we need not wait for the bacteriological diagnosis. We'll go ahead with empirical treatment, see for the clinical response.
Okay. Thank you so much. It was a
Thank
nice
you.
presentation.
Thank you, ma'am. Thank you so much. Thank you, ma'am.
Thank you. Thank you, Dr. Shanti Madam, Dr. Kartika Prabhu Ma'am, and Dr. Archana and Dr. Ashika presented very well. And we'll move on to the next session, which is a scientific session. Our chairperson is our beloved Madam.
Kartika, 1 minute. Shanti and Kartika Prabhu, sorry, yesterday I usually I'll inform them with 5 days earlier. Very sorry.
It's okay,
This time I
madam.
didn't inform. Thank you.
Thank you so
Thank
much,
you,
madam.
Shanti.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Okay. Anju Soni has joined us.
Yes, ma'am.
Anju Soni.
Dr. Angela, ma'am, சொல்லுங்க ma'am.
Anju Soni join பண்ணிட்டாங்களா?
I am a chairperson.
ஆமா.
Yes, ma'am. I called you.
எங்க சொன்ன நீ காலையில தான் போன் பண்ண. chairpersonலாம் சொல்லவே இல்ல. அதான் நான் கேட்டேன் what is
அட
my role
இதெல்லாம்
also.
சம்பத் குமாரி போட்டது. It is understood.
சரி ஓகே.
Sorry, madam.
Okay,
chairperson சொல்ல scientific session.
எங்க அஞ்சு சொன்னிய காலமே.
அவங்க வந்துட்டே நான் ஜாயின் பண்ணுங்க மேடம்.
சரி சரி ஓகே.
நான் கால் பண்ணேன். இப்ப திரும்பி கால் பண்றேன். கால் பண்ணேன் வந்துறேன்னாங்க 5:30க்கு.
2:30 இல்ல 4:30 இருப்பாங்க. நமக்கு 24 தான ஆகுது.
ஆமாங்க. 5:30 நான் இப்ப கால் பண்றேன்.
Ashika and Archana, you did a good work.
Thank you, ma'am. Thanks for the opportunity, ma'am.
இப்போ ஒரு தடவை கால் பண்ணிடுறேன் மேடம். மஞ்சு மேடம்.
இல்லனா அஞ்சலக்ஷ்மி மேடம் ஹெச்ஐவி அப்டேட் பண்ணிடுவாங்க.
ஓகே மேம்.
ஐயோ, சும்மா
இல்ல அவங்க
சொல்லுங்க.
வந்துடுறேன்னாங்க ஆக்சுவலா. நான் ஒரு நிமிஷம் கால் பண்ணி
6 minutes
இப்பதான் பேசுறேன் ஆக்சுவலா அஞ்சு சோனி மேடம்கிட்ட. அவங்க சிஐ வேற அப்டேட்டடா கொடுக்குறேன்னு சொல்லி அனுப்பியிருக்காங்க மேம் இப்போ.
அதாம்மா இன்னும் 6 minutes இருக்கு. அதனால நீ பேனல் ஆரம்பிச்சிட்டியா?
ஆரம்பிச்சிடறேன் மேம்.
பேனலிஸ்ட் இருக்காங்களா?
ஆமா, காயத்ரி வந்தாச்சு.
Anju ma'am has joined.
Anju madam has joined. Dr. Anju is there. Anjalakshmi madam, you can introduce Dr. Anju Soni. She has joined.
Anju,
welcome.
Okay. Good evening, everyone. I'm very happy to introduce Dr. Anju Soni. She is a friend of mine, and she is Vice President Foxy 2026 and President IMS 24-25 and VP Endometriosis Society India 25-27, Secretary General IMS 22-23, Governing Council member and member India CCM, Chairperson HIV and AIDS Committee, President JOGS and Committee Chair for Public Awareness and IMS, President Jaipur Menopause Society, and so many posts she has got. And she is editor of Voice magazine, Foxy trainer, basic and advanced endoscopy, vaginal trainer, master trainer, and all academic qualifications she has got. She has got many awards, Silver Jubilee Award and Appreciation Award as organizing chairperson, Appreciation Award by NARCHI, Excellence Award for Women Healthcare by AWA, and with so many academic accolades she has. And I'm very happy to introduce Anju Soni. Anju Soni, now it is the podium or the stage is yours.
Thank you for your kind introduction. First of all, before
by the way, how are you, Anju Soni?
So before I share my screen, I would like to give my best wishes to none other than my beautiful friend, Dr. Sampath Kumari Madam. Are my slides seen?
Yes, it is seen.
Yes.
I was telling Anju Soni is a diamond girl.
No, not. So thank you very much, Dr.
What
Sampath.
girl? Diamond.
Yes, sir.
Thank you very much for involving me today for today's CV, program, because all of you know, Dr. Sampath also knows that HIV is so near to my heart that, when I talk of HIV, my heart gets melted. So whenever somebody says HIV, I am there always. So thank you, Dr. Sampath, for your beautiful invitation. And also, I would like to wish you success in all your future endeavors. We all know how dynamic you are. And that is so very much important that we are all with you. So it is very, so it's very, very, very important for all of us to know that HIV in pregnancy is very crucial problem, and all of us sometime or other come across these problems. So we must know what we need to do. So let me just begin my presentation by saying that, just as one might predict, because we have all gone through a very different phase of life in last 3-4 years. And when we were going through the endemic of Corona, we must have thought of these lines, which are just as one might predict for a disease that is not yet fully understood, as well as extremely recurrent to the treatment, has essentially provided a large-scale occasion for metaphorizing of illness. And these lines, we always think that these were for Corona, but these were said much earlier in 1989 by Senteng as in his books AIDS and its Metaphors. And what more that, there are people who have gone through both the crises like COVID-19 and early AIDS crisis. And I know during Corona times, almost each and everyone's themselves or their family suffered from the, suffered from this diseases. So we all can, still when we think of this corona times, we get shivers in our body. And there have been similarity between SARS-CoV virus and HIV virus. But what is different is that HIV virus changes structure more than 100 times in 24 hours. That is why over last so many decades, more than 4 decades, we have not been able to come out with a vaccine for HIV, and the only treatment is prevention, and also taking regular medical treatment, which has been there with us for a management of any chronic illness per se. Whenever we talk of this pandemic, HIV and AIDS is, I believe, the longest pandemic. It was discovered in 1981, and then in 1983 the virus was identified. In 1987, ZUV therapy was initiated. In 1990, the epidemic was controlled in developed countries. But then in 1990, when the pandemic was controlled in developing countries, there was an explosion in the developing world, with first case being found in our own country, and then global and national responses were alarmed, and then goals were formed all over the world. With in 2007, the dual role, the elimination of mother to child transfer and syphilis was initiated in 2014. Again, the initiative of elimination of by WHO was validated in 17 countries. We also aim to validate this by 2020 as our SDG goal, but because of Corona, we pushed behind. And in 2020, for this year only, we have just launched again the dual elimination from HIV as well as syphilis. Whenever we talk of HIV statistics globally, we know almost 5 million people have been on ART, and there are about 38 million living with HIV. There have been 1.7 million newly infected, and they almost 0.7 million died from AIDS or AIDS-related illnesses. 75 million infected since the start of epidemic, and 32 million died from AIDS-related illnesses. And whenever we talk of Indian scenario, we all know that HIV, though has a low prevalence in our country, 0.34%, but we are the third largest number of PLHIV in the world, with more than 2.1 million people living with HIV, and about 40% of these are women who are carrying this infection, and almost 21,000 children are infected every year, with nearly 5% of infection attributed to mother to child transfer, and the 70,000 children more than 15 are living with HIV, and a small proportion is also infected with unsafe injections or blood transfusion. So let's talk of some cases which come to our practice regularly. Mrs. A presented in first trimester in her antenatal clinic. She is an HIV reacted. What treatment should be given to her, and when? What are the risk factors for her during and after her pregnancy for mother to child transfer? And if she never turned up for follow-up or treatment and presented directly in liver, then what steps should we take? Another case, a 30-year known case of HIV, is presenting with 3 months of pregnancy. She was diagnosed with HIV positive 5 years back during her previous pregnancy. She received a single dose of Neuropain during delivery, and her current CD4 count is 570 and hemoglobin is 10. So whether she needs an HIV, if no, why? If yes, why, and which regime? What could have been done to prevent this pregnancy? Another case, Mrs. C, diagnosed with HIV positive 7 months back in her first trimester. She gives history of being provided with some medications following that, which she had taken till delivery. Now she is reporting back with 5 months old breast baby. So what are the next steps we want to suggest to this mother? So we all know that vertical transmission is a very important route for any new infection in the children, and fast progression takes place in the infected children. Over half of the children less than 2 years die if not diagnosed early. And the number of annual new infections in 2022 was estimated to be almost 67,000, And out of this, when we looked at the children who are 0 to 14 years, it accounted for about 6% of total annual new infections. Again, it is very important route of transmission for new infection, and the first and when we look at the form of PPTCT to EBTH and the guidelines, what is very important that it has a long road which we have traveled from 2002 to 2022, where we have rolled out a plan and where we are looking for India to have the status of validation by 2026 and by 2030. So we all are looking towards the elimination of mother to child transmission by 2030. So I request all of you to gear for this and help us. For that, we need to eliminate the vertical transmission of the HIV and syphilis from mother to child. And this is main anchoring of national response towards ending the AIDS epidemic. Now, when we look at the prevention prongs, we all know that there are 4 prongs which start with first prong being primary prevention of HIV, especially among the women of reproductive age. In the prong 2, we talk of prevention of unintended pregnancy among the WHIV, which is the second case I discussed. And in prong 3, we talk of prevention of vertical transmission of HIV and syphilis during pregnancy and childbirth. And fourth is provision of care and management of service for infected women and their exposed infected children during postnatal and breastfeeding period. So our target is to prevent and control HIV and AIDS, and for that we have 95% of people at more risk of acquiring infection use comprehensive prevention. The targets are 95, 95, 95. 95% of HIV positive know that their status. 95 of those who know are on treatment, and 95% of those who are on treatment have suppressed viral load. And in more than 24 states, we have been able to achieve the second goal, which is very heartening to know. And this is all because of the work of our FOXY members, the gynecologists, and the government, who are working very hard on this. So 95% of the pregnant and breastfeeding women living with HIV should have suppressed viral load, and less than 10% of people living with HIV and the key populations experience stigma and discrimination. This is another very important point we must keep in mind, that all these people are experiencing a lot of stigma. So whenever we talk of the treatment, it is very pertinent to know that whenever we talk of HIV care, it is a continuum of HIV infected pregnant woman during pregnancy, breastfeeding, and all her life. And the care starts in antenatal period with PPTCT service, where we initiate the antiviral therapy, continue it throughout the intranatal period, and then postnatal period and throughout the life. And during all this period, counseling and testing in all phases and encouraging institutional delivery is very, very important. And all these things tell us that we must link all these patients to the ART services and do CD4 counting and viral count. So what are the factors which prevent the prevention? So there are factors which are there during the pregnancy, during the labor and delivery, and during the breastfeeder. And the major factor is the viral load in the mother. So ART to HIV positive mother and ARV prophylaxis to the baby reduces the risk of transmission. And when we look at the percentage of spread, we all know that the maximum transmission is during the delivery or labor and followed by breastfeeding and pregnancy. So we must look into the prevent this spread during the labor, and what are the points we have to keep in mind. So we all know that when we talk of the maternal risk factors, the high viral load resistant virus, advanced clinical stage, concurrent STI, recent infections with viral, bacterial, and parasitic infection, and of course malnutrition, these are very important factor for mother. And when during the labor we talk about uterine manipulation in any form, maybe external cephalic version, PROM more than 4 hours, placental abrasion because of placental disruption because of abrasion of choriamnitis, intrapartum hemorrhages, invasive delivery techniques, including episiotomies and vaginal delivery versus cesarean is a big debate. We are going to talk about it. So the most important factor for transmission is the high viral load in the mother. So when we talk of intervention during pregnancy, first very important is primary prevention of HIV in childbearing women. Provide HIV information to all pregnant women. Antenatal visits should be taken as opportunity for prevention of parent to child transmission. Prevention of unwanted pregnancy should be done in all HIV positive mothers. Prevention of PPTC through ART should be done, and nutritional quality is very, very important. I just stated, and then counseling for delivery, I'm saying once again, is very, very important. So if a pregnancy is newly registered in an ART center, we must start ART, of course, after proper counseling preparedness. Continued ART throughout the pregnancy, delivery, and thereafter lifelong. I am again and again stressing that the ART doesn't stop after delivery. It has to continue lifelong. Even if the woman presents very late, at 36 weeks, we must initiate ART promptly. And this should be initiated ideally in the ART centers, but you must start even if the patient has all the reactive tests, and we must refer them to the ART centers. So the current PPT-CT guideline says that all positive pregnant women, breastfeeding, or women to start with ART, irrespective of CD4 count, WHO staging, and duration of gestation. It should be done, it should be lifelong and triple drug, and there are different regimes available. So what are the goals? There are clinical goals to prolong the life and improve the quality of life. Immunologically goal to talk of quantitatively the CD4 count with the normal range, and qualitatively the pathogen specific immune response should be there. When we talk of virology goal, the greatest possible reduction in viral load as long as possible to halt the disease progression to prevent the delay and resistance. The therapeutic goal again is very important because there are three goals to achieve: maintaining the future therapeutic option, minimizing the drug toxicity and side effect, and maximizing the treatment adherence. And then reduce the HIV transmission in the epidemiological goal is possible. So how does the ART team work to prevent the vertical transmission? So it is very important that we should know viral load before starting the ART, and then after once we have started the ART, the ART should be sufficient enough to make it possible to be almost no viral load in the patient, because that will improve the maternal health, prevent the HIV virus replication in the baby, and reduce the reducing the maternal load, achieving viral suppression, and lower the risk of transmission. And basically, undetectable is equal to untransmittable. That should be our aim for preventing the transmission. So what should we start as a treatment? So the first line treatment, as per the new, latest guidelines, is we give a TLD, tenofovir, lamivudine, and dolutegravir, and it can be given to all the PLHIV above the age of 10 years, more than 30 kgs of weight, and it is effective for HIV1 and 2, and history of exposure to single dose of nevirapine. It is also very useful for women who have a TB with HIV co-infection, and it is given a dose of tenofovir 300 milligram, lamivudine 300 milligram, and dolutegravir in the 50 milligram. So TLD, one tablet to be taken once daily with or without food at bedtime or any other time fixed as per the patient's convenience. So as per the WHO 2019 guidelines, there are multiple benefits of TLD. It has greater maternal viral suppression, fewer maternal deaths, fewer sexual transmission, and fewer mother-to-child transmissions. And DTD is predicted to be more cost-effective, and it outweighs the risk of, there's a slight increased risk because of increased weight gain, which is a side effect of this drug. We'll come to it in later part. But there is a slightly extra risk of pregnant woman from 1% of neural tube defects in a normal woman. And when the patient is on dolutegravir, the risk increases to 2%. So there is a slight increase. So we must shift the patient to Deltavogir after properly counseling and telling her that these are the risks, explaining her very well all the benefits and the problems. And then if patient is agree, then we give. If patient is not agree, then we have to give her an older regime, that is TLE, tenofovir, lamivudine, and effervescence. In case she's taken nevirapine or she's got both infections, HIV-2 or HIV-2 and HIV-1 and 2, then we give her tenofovir, lamivudine, lopinavir, ritonavir combination. So this has to be kept in mind, that counseling is very important. So to be very concise, that WHO and NACO recommends first-line ART for all the PL-HIVs to be TLD, and women of childbearing potential should be allowed to make an informed choice after explaining the benefits, as well as slight risk, which I have just stated. And there are numerous benefits, as I have already narrated: the faster and greater viral suppression, few mother-to-child transmission, fewer side effects, higher barrier of developing drug resistance. Hence, NACO recommends transition of all the patients to DTG-based regimes, and they have to be advised of healthy diet and regular exercise to prevent the extra weight gain because of the side effects. It is very important to do a viral load testing at 32 to 36 weeks to determine the risk of HIV transmission, because this test is to be done irrespective of duration of ART. And then once we have the result, the risk of infants will be advised single ARV prophylaxis for 6 weeks, irrespective of the feeding options. If the baby born to the mother with more than 1,000 copies or with no viral reports, then they are to be categorized as a high risk for HIV transmission. And these high risk infants will be advised to take dual drug therapy, ARV prophylaxis, and duration. That will depend on the feeding options. So the HIV risk categorization is based on maternal viral high load. If the infant is born to HIV positive mother, not on ART, and maternal viral load not done between 32 weeks of pregnancy till delivery, or viral load results are not available, unsuppressed maternal viral load between 32 to pregnancy, that is more than 1,000 copies, are again high risk, and mother who is newly identified within 6 weeks of delivery are again high risk. Only the women who are infants who are born to mothers with suppressed viral load at 32 to 36 weeks with less than 1,000 copies are low risk babies. So the dosage schedule, I have already said that we give TLD in a normal 300, 350, and we have to look for the side effects which wear off as the medicines are continued, but we must keep them in mind so that we can tell patients to come to us. So WHO recommends that ART should be given to all patients, and women should be allowed to take an informed choice, and there are numerous benefits, as I said. So the recommendations continue. So the counseling for ART adherence and healthy practices is very important. Knowledge of precautions to be taken by the pregnant and breastfeeding mothers, regular condom use to avoid STIs and reinfections of different states, adherence to ART during pregnancy, labor, and breastfeeding. I cannot emphasize, will continually emphasize that it has to be there throughout the life. So antenatal counseling for breastfeeding should be started from the first visit. Mother should be prepared. Then we reinforce the counseling postnatally. We should start the care of nipples and breasts at the beginning of pregnancy in the first antenatal visit, and counseling for nutrition and food handling for the mother and safety is very, very important. We must continue iron and calcium throughout pregnancy and breastfeeding. When it comes to the mode of delivery, as per the guidelines, cesarean is only done for obstetric reasons, and use of ART can reduce the risk of mother to child to almost zero, and patient can go for vaginal delivery if her viral count is less than 1,000, and use of ART suppresses the viral load, thus reduces the risk to less than 1%, which is very, very important. So we must emphasize that these women should take antiviral treatment for for 6 months before the delivery. So during the labor, we must know what we should keep in mind. We must minimize the vaginal examination, use partiogram so that we know that the labor is not prolonged. And if the labor is prolonged, we must start oxytocin to shorten the labor. We must avoid PROM in these patients. During the labor, we avoid all the procedures, even avoiding routine episiotomy and proper perineal support is very important. No use of forceps or vacuum extract cord clamping after it starts pulsating. No milking of cord, and when the head is delivered, wipe the infant's face with towel, and after the baby is delivered completely, thoroughly wipe the baby dry and wet from the liquor. So, if a woman presents directly into the labor and we do not know her status, then the labor room must offer her a bedside counseling and HIV test by whole blood finger prick in the labor ward after taking the consent. Detect HIV positive. If she is detected HIV positive, the MOC of labor room will initiate TLD from the labor room. You must have a tablet of TLD in your labor room, in your wards, in your ICU, in your HDU, in your OT, so that we should have it handy with us, and all ART center provide it free of cost to us, so that even if there is a post-exposure risk of post-exposure prophylaxis, we must start immediately without waiting for the results. So we must ensure confirmatory HIV testing, and labor nurse may inform the ITCT consular lab technician to confirm diagnosis, and then link the patient to ART center. ART initiation, ARV for prophylaxis should be given to all HIV mothers. Now, when we talk of infant feeding practice, it is very essential to know that mother's milk is very important. It's a complete food. It contains antibodies which protects them from against all other infections, including HIV also. And all ARV interventions for mother during pregnancy, labor, breastfeeding, and to the infant during breastfeeding can significantly reduce the risk to less than 5%. And replacement feeding has shown to be associated with higher risk of infants dying from infection in the low resource limited setting. So, ideally speaking, the mixed feeding should be avoided. Feeding the beyond 6 months, we should start the other feeds, and the mouth source in the infant, you should avoid the feeding. Then, as I have said, that exclusive breastfeeding is the best option. It is nutritionally complete food for a child for first 6 months, and ARV intervention for mother reduce the risk to less than 2%. Thus, in the view of scientific evidence and PPTCT interventions, breastfeeding is recommended as the optimal infant feeding options in India. Breastfeeding should not be stopped abruptly. It should be stopped slowly, and with ongoing optimal maternal ART, there remains no difference in feeding guidelines for HIV exposed versus unexposed mother. And as per updated NACO guidelines on breastfeeding, the exclusive breastfeeding for minimum 6 months is very important. And after 6 months, a patient should be introduced with appropriate complementary feeds and continue breastfeeding. Although exclusive breastfeeding is still recommended during first 6 months, practicing mixed feeding is not a reason to stop breastfeeding in presence of ARV drugs. Because some mothers may be working, so they have to practice mixed feedings. And breastfeeding can be continued up to 24 months or beyond, like general population. Exclusive replacement feeding may be considered only when breastfeeding is not possible. So, informed choices for to mother only for all the 6 criteria for replacement feeding. That is the FAST criteria, which I'm going to talk. These 6 criteria are that patient should have a safe water and sanitation to assure the household and community, can reliably afford provision of sufficient and sustained replacement of feeding to support normal growth and development of infant, and can prepare feeds frequently enough to clean in a clean manner so that it is safe and carries low risk of diarrhea and other malnutrition. It can, and if in first 6 months exclusively give replacement feeding, and family is supportive in this practice and can access healthcare that offers comprehensive child care. So replacement feeding has been shown to be associated with higher risk of infant dying from infection in resource limited settings. It is also found that over-diluting replacement PD results in insufficient nutrition, inappropriate complementary foods, unhygienic condition, poor sanitation, and safe water are very important to keep, that they should not be there while for preparing the replacement feeding. And adverse socioeconomic conditions such as poverty, food security, and parental limited paternal education are also important. So, in view of scientific evidence and interventions, now we are recommending exclusive breastfeeding, as I have said, for 6 months, followed by complementary feed, and it can continue for 2 years. It is not to be stopped abruptly, and ART has to continue during pregnancy and lactation, and thereafter, replacement feeding should be considered only if a fast criteria are met, that is, family accepts feasible, affordable, sustainable, and safe water is available. So, to recap, whenever a patient comes to us, we can get different case scenarios. Patient woman can come to us detecting during the routine antenatal care, that we ensure that if she is tested reactive, we immediately link her to the center. Then the ART center performs CD4 testing, viral load count, and register her, and then ensure her delivery in the institution, and follow the viral load and institutional delivery later for the baby also. So when a woman comes to us who is already registered in a ART center, we need to follow her, remove all the fears she has, follow her up, treat all policy, then perform CD4 count viral load testing as per the guidelines, and then regular follow-up. Then woman who is already on ART continue the ART regime. Woman who comes directly in the labor, perform a confirm test. If she is HIV reactive, start her on TLD, initiate immediately to confirm, and then connect her to the center for later and give ART to the infant. If the woman is detected in the postpartum period, then link her to ART immediately, perform CD4 counting, initiate ART, and then regardless of a CD4 count, give her the ART, and after that follow the mother as well as the baby both. So the PPT here is a continuum of care of HIV pregnant woman and breastfeeding woman, and the care continuum is in the pregnant and breastfeeding woman is HIV testing, then connecting to ART and ARV, adherence to the and retention and linkage to the ART centers for lifelong. We have all been listening to our own president talking about Atmanirbharta, and for only when I became the chairperson, I knew this amazing fact that India manufactures most of the drugs that are used to cure HIV around the world, which is an amazing fact that most of the people don't even know. And it is so funny because the only time I take HIV is think about HIV when I have to take a tablet, take a medicine of HIV. So no child should be born with HIV, no child should die because of HIV, and no child should become an orphan because of HIV. Thank you very much. Before ending my presentation, I just want to share that when I was chairperson, I went to Jodhpur. There was a orphanage.
Anju?
Yeah, something.
As usual, you are the expert of HIV in pregnancy. I told you, no, every time I used to tell there will be no patients with HIV complicating pregnancy. After you have worked as a HIV committee chair, and now the chair itself, a committee itself is not there. Thank you, Anju. Thank you so much.
Thank you, Dr. Sampath, and best wishes to you, and love.
Anju Soni, that was an excellent talk. Anju Soni, Dr. Anjalakshi here. It was an excellent
talk.
Good
evening, Dr. Anjalakshi. Thank you so much for introducing me.
Beautifully posed the problems, and then you have answered everything, and your last flow chart has given.
I think some problem with the network. I think she has some problem with her net.
Network.
Yes, she has some problem, I think. Anju, thank you so much.
Thank you, Dr. Sampath. Thank you so much.
Thank you. Sakiti, you can proceed with the question.
Okay, ma'am. First question. I request all the delegates to answer the question.
Sakiti, only one question now. Another is after the panel discussion.
Okay, ma'am.
Okay.
Yeah.
1 minute. How much is the duration for the answer is 1 minute.
Time up.
Thank you, Sai. So we'll proceed on to the next program, which is the panel discussion. So myself and Dr. Gayatri are the moderators for this program. Dr. Gayatri is a consultant obstetrician from SMS Hospital. I think she is also in an emergency now. Dr. Renju. Dr.
Ma'am,
Renju.
yes, ma'am.
Yeah.
Yes, ma'am.
Good evening, Dr. Renju. I invite Dr. Renju MS, who is an assistant professor at Erode Medical College, and she has done a UG in Trichy Medical College and PG in Thrissur. She is a faculty in national state conferences, has participated in all the conferences, joined Secretary Erode OG Society, and she is the IMA Treasurer Dharapuram and organized member of Erode OG Conference in 2022. She has won the Best Female Doctor 2018 award. Well done. It is a very difficult task indeed. And Best Sterilization Services Award from 2018, 19, and 23 by the Family Welfare Department of Tamil Nadu. She is interested in high-risk obstetrics, infertility, endoscopy. Really great service, Dr. Renju. Then I invite Dr. Kogila Devi, who has done a UG from Sri Lakshminarayan Institute of Medical Sciences, MSOG from Stanley Medical College, and she's a professor, assistant professor of OG in Government Thoothukudi Medical College.
Good evening.
Good evening. And I invite Dr. Uma Brinda, who's a student from, who has done her UG from Government Tanjavur Medical College and post-graduation from IOG, Madras Medical College, and she's an assistant professor currently in Obs and Gynae, Tanjavur. And she's the present secretary of Tanjavur Obs and Gynae Society, and she has interest in high-risk obstetrics. Welcome, Dr. Uma Brinda.
Yes, madam. Thank you.
And I invite Dr. Swati Rathore, who is a professor professor of Department of Obs and Gynae, Christian Medical College Hospital, Vellore, and she has done her senior registrarship in Safdarjung Hospital in New Delhi. Is madam here?
Yes, ma'am. Yeah, thank you, ma'am. Yeah.
Welcome, ma'am. And she has numerous publications and she's quite famous. And so, shall we start the panel discussion now? Sahiti, can you please the reverse?
Yes, ma'am. Just a second, ma'am.
Okay. So it's going to be a short discussion because of today's festival. It's a festival day. Yeah. So Miss B, who is 20 years old, unmarried college student, and with a history of vaginal discharge and for 10 days, and with a profuse foul-smelling yellowish green discharge and on and off spotting, has come to our OPD. So what are the other history we will take in this case? Dr. Gogila Devi.
Yes, ma'am.
So this patient has come with anxiety. Can you please play the previous slide? What is the other information we will need in this case?
I will, as she is a younger 20-year-old female, I will ask about her coital history, sexual history, and any previous history of similar complaints. And I will ask whether she had any fever. And I think
Lower
I will ask.
Yeah.
Yes, ma'am. I will proceed asking those, ma'am.
Okay. So, Dr. Renju, anything more?
Ma'am, whether she has fever associated with abdominal pain, and because she is a college student, we would have to. It has already been mentioned, ma'am, the sexual history and all.
No. Please go to the next slide, Sahiti.
I think antibiotic, whether she has taken for a long duration, or she is on steroids also, or she is diabetic, and definitely the OC pills, even 20-year unmarried also, yes.
Yeah.
For a long duration can cause the increase in the discharge and all.
Okay, very good. So we'll move on to the next part. So the next slide, please, Sahiti. So we will have to also ask for itching. It could be a fungal infection, which is common among most of the females these days, especially the jeans and tights they wear. It is also common fungal infections and the fever, abdominal pain, and OCP. Okay. Then the coital history, and we should discuss confidentiality in this during this when we take the history, as most of the girls as well as women, even working women, if we ask in a OPD with a nurse and with everybody around, they will not be ready to disclose. So when we do an examination, it is a good thing to tell them that it is information is confidential, and we will not judge them. We will not judge them based on the history, and if we tell them, then they will give the history of extramarital. I mean, in case of married women, they will also disclose this extramarital affairs and those things. But whatever it is, we should take a history of coitus, recent coitus, when was the last, and how was the partner, what occupation, because quite common with the drivers. I think I shouldn't again judge, but that is also a common thing where they have PID. The women have PID and sexually transmitted infections. So
Radhika, உன் வாய்ஸ் கொஞ்சம் கிளியரா இல்ல, கொஞ்சம் நல்லா
சரிங்க மேம். Okay, Sahiti, next slide, please. Okay, what are the findings we will expect in this girl? Dr. Uma, ma'am. Uma Brinda. Dr. Uma, ma'am.
Yes, madam.
What is the examination findings we expect?
Madam, she is unmarried and local examination can be done, madam.
Okay.
Vaginal examination could not be done in this case, and any other lesions that should be noted, madam.
Okay.
Ma'am, maybe per abdomen examination we can check for the tenderness, probably pubic or the right and left iliac and the upper abdomen, ma'am.
Absolutely. Commonly, the surgeons refer to us, the cases with the lower abdominal pain, especially appendicitis, can also be confused with PID. But in PID, we have both, as Dr. Renju said, it will be a lower abdominal pain, generalized lower abdominal pain, and if the infection is severe, it will be a generalized abdominal pain. But in appendicitis, it's more likely to be in right iliac fossa alone. Okay, so we will look for other signs of even other sexually transmitted infections or any other discharge. So we will collect the samples. So we'll, in case of a married woman, what are the things we expect in a married woman? If it is a married woman, we will do a
If she is
pervaginal.
married, we should do a speculum examination, look at the cervix, how the discharge is, and collect the discharge for wet mount and KOH mount, madam.
Okay.
We can do a pervaginal examination and we can also look for some spots, maybe some.
Okay.
And the pervaginal examination tenderness will be there.
Yes,
Discharge
yes.
will be the foul smelling or the color. We can check on that. And especially the phonesis will be free if it is a PID in a married woman.
Yes, ma'am.
Other than the tenderness. TO mask can also be felt.
Yes, ma'am. Yes, sometimes the bog is swelling only if that is a big mass. And very rarely, if it is a chronic PID and recurrent chronic PID, uterus might be fixed. But in the early stages, usually it is only the tenderness and cervical motion tenderness, and we can feel. Excellent, madam. So what are the investigations? So next we will with the investigations. Examination includes temperature. Usually they are febrile. If it is a acute severe PID, infection is severe, then they will have a raised temperature up to 101 or even more than that, rigors and tachycardic and blood pressure. Sometimes they can present with sepsis also. And as we saw, abdomen exam, generalized tenderness. And so we will move on to the investigation. So what are the investigations we are intending to do?
Regarding the blood investigations, we can do a CBC and look for increased total count, ma'am. We can do a ESR and a CRP also.
Okay.
And urine examination is a must, ma'am, because PID associated dysuria and UTI will be there. And the swabs, regarding the swabs can be taken from the cervix, vagina, and from the posterior fornix too, ma'am. And blood culture is usually not done, ma'am. Maybe after the swabs.
Yeah, we can do a blood culture too. To rule, if they have fever, then we can do a temperature of around 100 or more, then we can do a blood culture also. The way the vaginal culture is enough.
Yes, ma'am. We can do
the HIV and syphilis also in this. Sorry.
Yes, ma'am.
We should do the HIV and syphilis also in there.
Definitely. Yes, ma'am. Triple H, all the syphilis, HIV, and all the three.
Yes, ma'am. She has been sharing the toys with the others. So.
Yeah.
Oh, okay.
Okay, then. So gonorrhea, chlamydia for CB NOT test and trichomonas also we will do pet mount. So sometimes they can also present with lesions, herpes lesions, vesicular lesions, and it will be very painful. In those cases, we have to treat them with the antiviral also. And sometimes they will present with the retention of urine. And we have seen 2 or 3 cases of herpes, in which cases we have to even catheterize the bladder for a couple of days and then start the acyclovir. Okay, next slide, please, Sahiti. So now what is the treatment for this patient? Kogila, Dr. Kogila?
Yes, ma'am. As it is appearing like a greenish discharge, I might think it has a trichomonas, and I think the partner will be needing a treatment.
Yeah.
And
First,
yes, ma'am.
The patient, what do you, if it is a PID, what do we start with? What is the antibiotic?
Actually, basically, we will treat the patient with the metronidazole along with the doxycycline, along with the ceftriaxone and a single dose IM injection 500 mg.
Okay. So we use ceftriaxone 250 milligram or 500 milligram based on the weight.
500 mg at least.
Yeah, single
dose. And based on the severity, metronidazole as an injection, as a loading dose, or 14 days tablet along with the doxycycline.
Okay, it's best doxycycline, the standard treatment with metronidazole and to prevent infection. And we should have a low threshold to treat PID to prevent the sequelae. And further discussion. So do you think the partner, we need to definitely advise the patient to bring the partner here, or she has to be, I mean, the partner, she or he has to be treated definitely? And what are the long-term consequences of PID?
If it is a chlamydia, gonorrhea, then probably it is like she is likely to end in infertility, ma'am, because of the tubal damage and probably she can develop peritonitis or pelvic abscess. She can get chronic pelvic pain too because of that.
Yes. And even ectopic pregnancy also. You should also tell them that there is a risk of ectopic pregnancy. And as you said, long-term pelvic pain, chronic pelvic pain. So the contraception, what is the contraception? And prevention of further PID or
The vegetable use of barrier, ma'am. We can avoid
more.
Yes, condom. Condom and even female condoms are available.
Yes, madam.
Yes, ma'am.
Yes, madam. Yes, madam.
So, madam, what is the contraception? Do we have to insist on contraception?
Better. We should advise on barrier contraceptives, madam. Either male or female condom is advisable, madam, for these patients.
Yes, ma'am. Okay. So the counseling and what is the follow-up of the patient? How do we follow up the patient, ma'am?
If the patient is treated as a monthly basis, then we will call the patient by 3 days and look for the progress.
Okay. After a week, we should bring the patient back. And what are the conditions, indications for admission of the patient?
When the patient is febrile and when the patient is febrile with acute abdominal pain, she needs admission immediately.
Okay. And as we treat any other febrile illness, we need to give them good hydration and antibiotics.
Yes, madam. And an ultrasound should be done.
And what is the recent mode of investigation? There are a few guidelines, BASH guidelines, another, it suggests MRI, I mean, ultrasound is the first anyway, but the next mode, non-invasive mode is the MRI also. And
okay.
It clearly shows hydrosulfings and also the thickening of the tubes and everything.
Yes.
And if we have a doubt and we need to rule out any surgical cause, then laparoscopy can be done and abscess can be drained. But usually, if we are confirmed and we are sure that it is a pelvic inflammatory disease, rest and IV fluids, IV antibiotics for a week will relieve them. And next slide, Sahiti. Sahiti. Okay. So what are the other causes of pelvic inflammatory disease?
And the most common thing is intrauterine contraceptive device, ma'am. Copper T that we put.
Yes, ma'am. Absolutely true. We keep the many of the patients do not know these days the postpartum IUCD prevents pregnancies, but many women come back with profuse white discharge, and sometimes we need to remove them. But we should tell them that removal will cause. We can treat them with antibiotics, and then later on consider removal only if it is not, if it is relieved. The symptoms are not relieved. If it is a mild one, we can cover it with antibiotics. But if they are diabetic or they are immunosuppressed, then better to remove the source of infection.
And she has been using too much over-the-counter drugs, ma'am. So this is likely to cause decreased lactobacillus, as mentioned in the PowerPoint earlier. So she'll have to take more of probiotics, ma'am.
Yes. Swati, madam, any other?
Chemical irritant better to be avoided. Chemical irritant to be avoided. And mainly the V-wash or feminine washes. Many patients use these washes, and that is also not advisable.
Yes. And douching, some of them will douche with a shower, which is not, especially nowadays, the shower is available. So many of them think they can clean the vagina with the shower, but they should not do that. That will also cause PID, actually can infect. And also we should advise the patients, women, not to have sex during periods. The younger girls and women do not know that during, because blood can alter the pH of the vagina, increase the infection, and after abortions and any miscarriage abortions, and after periods, it's best to avoid, during periods and after abortions for at least a month or 6 weeks, we should tell them not to have intercourse or have intercourse with a condom. Otherwise, it will cause further damage to the tubes and the uterus. So these infection markers are not always necessary, although we do those CRP and these things, it doesn't completely, it is not absolutely needed. It is only a supporting evidence, but we have clinical symptoms and clinical signs of acute PID with the vaginal discharge and abdominal pain, cervical motion tenderness. We can start them on antibiotics, oral antibiotics, and treat them early. Next slide, please. So this is a chart with physiologically we have to differentiate between the leukorrhea and the other types of infection, bacterial vaginosis and vulvovaginal candidiasis, trichomoniasis and cervicitis. Next slide, please. So, madam, what is the commonest cause of PID? Uma Brinda, ma'am. Uma Brinda, ma'am.
Yes, madam.
Commonest cause of PID, pelvic inflammatory disease. Chlamydia
and gonorrhea, madam.
Okay, ma'am. And nowadays, self-collected vaginal swabs are also there.
Yes.
And we can do that. And single dose of azithromycin 1 gram orally or doxycycline 100 milligram can be used. Next slide. I think we have covered most of them. So, Dr. Kohila, can you see the slide? You can.
Yes, ma'am. Yes, ma'am.
Then you can maybe read out the slide.
Yes, ma'am. Shall I read it out, ma'am? Yeah. A common cause of vaginal discharge in adolescence is physiological leukorrhea, presenting as clear yellowish odorless discharge with fluctuates in consistency and volume throughout the menstrual cycle. Vaginal discharges can originate from the vagina, that is physiological leukorrhea, or bacterial vaginosis, or from the cervix, which can be chlamydia or gonorrheal mucopurulent cervicitis. Bacterial vaginosis and vulvovaginal candidiasis are the two most common of the vaginal discharges. These diseases are not sexually transmitted, but rates may be increased among sexually active individuals. Chlamydia trachomatis and Neisseria gonorrhea are the two most common reportable sexually transmitted infections. Rate of these infections are highest among the adolescents and young adult females.
Thank you so much. One last thing. Many of the women with abdominal uterine bleeding, the commonest cause is in the reproductive age group is pelvic inflammatory disease, which mostly we all miss because we always think of hormonal these days. But the commonest cause, especially between 30 to 40 years, between 20 to 48, should say, is the pelvic inflammatory disease, which we all should remember. And especially the intermenstrual bleeding is the commonest sign with chlamydia. And postcoital bleeding. Postcoital bleeding is more common with chlamydia. And the other one we should remember is the cancer cervix. So especially in young women, speculum examination must be done. And if there is tenderness, we should start antibiotic, doxycycline, and metronidazole. That is the main message. Anything else? Dr. Uma ma'am,
Yes, madam.
you want to give any message, important message about pelvic inflammatory disease?
Madam.
Uma madam?
What about the syndromic management and all, madam? We
Yes,
in government setup have those color-coded tablets, and even we see paramedics giving those things, madam.
Okay.
For initial, then those kits can be used, madam, without testing, without any testing. These kits are given. Even in private practice, we have those kits containing azithromycin, metronidazole,
Okay.
fluconazole, used for mild abdominal pain with discharge and all. We are using those tablets, madam.
Okay, madam. Wonderful. And you do it. Do you do a speculum examination and then you do?
Yes.
Or
Yes, we will do a vaginal speculum examination and look for any lesions, whether there are any local lesions, and then we give those kits, madam.
Okay.
And examination is most important one, because most patients will complain of white discharge and pain, and we look at the lesion only, we can identify those herpetic infections and all, madam. Otherwise, azithromycin or metronidazole won't cure those lesions. So examination is the most important thing to do.
PID is more clinical diagnosis.
Yes, clinical diagnosis.
Yes, ma'am. Thank you so much. Dr.
Thank
Gokila, what would you like to add? Please.
Especially in this patient, white discharge, they are considering it is very normal. This chlamydia infection and all, it will be very asymptomatic and it will be neglected unless they will get married and when they are coming for infertility treatment. Only we are retroactively diagnosing they are having this infection.
Yeah.
Actually, they are taking this white discharge very lightly, and even though they are having very much of uveitis and all, they are not coming to the OP. When it is so severe, they will be taken.
Absolutely. By that time, the tubes are damaged. Yeah.
Yes, ma'am. So the health education is really important, ma'am.
Okay. Swati, ma'am. Ma'am,
Yeah, early diagnosis is the most important thing for this people. Whenever the discharge is there, if it is physiological, it's okay. Once it is pathological, anytime irritation, foul smelling discharge, or colored, immediately to be investigated and treated, because and at a war front level we have to treat. And if the fever is there, should need an admission and injectable antibiotic. If fever is not there, then oral antibiotic and then follow up. These are the message for this.
Thank you so much. Dr. Anju?
Ma'am, yes, ma'am. What we advise in OPD is the girls, young girls, when they come, we ask commonly, did you shave? They say yes. So after shaving third day or fourth day, they'll have that pruritus itching, ma'am. So mild discharge might be there, number one. Number two, after sexual intercourse, we'll ask the patient to pass urine, ma'am. Otherwise, there is a chance that it might ascend. Yes, ma'am. That is number two. And number three is during menses, they have to change pads every 6 hours, ma'am. If they keep it chronically, there is going to be some amount of infection which is going to ascend up.
Yes, absolutely. Wonderful points. Dr. Archana, madam, is she there? Dr. Archana?
I just want to add one more point, sorry.
Yes, ma'am, please.
Because they are using tampons nowadays. So I think we have to tell, we should tell them, removal of the tampon just like a pads, it is important. If by missed tampons, it is going to cause lots of problem and the long-term consequences are there.
Yes, ma'am. That streptococcal infection there can cause serious morbidity and even mortality. Retained tampons can cause serious infections. So thank you so much, Sampath ma'am.
Yes, Radhika. Last minute, thanks to last minute entry for MOC and for moderating the panel.
Thank you so
Dr.
much, ma'am,
Radhika.
for the opportunity. Thank you.
Okila, Renju Arun,
Second question.
Uma Brenda, everyone has done it. Fantastic.
Yes, ma'am.
Okay.
Yes, ma'am. Shall I launch second question, ma'am?
Yes,
Radhika, you can pose the second question.
Long-term effects of PID. Ectopic pregnancy, infertility, chronic pelvic pain. Fourth is all of the above.
Five more seconds. Yeah. Time up.
Yes, I think both the winners. So in spite of our Tiruvannamalai Deepam, we had around 32 people. Really, I thank all the delegates. So first, I should thank Dr. Rajendra Singh Pardesi, who accepted to be the chief guest, and Vidya Topi for guest of honor. And Anjalakshmi Madam, I forgot to inform her, in spite of that, she has joined as a chairperson. And Anji Soni, the speaker, who has joined from Jaipur. And the moderator, Dr. Radhika Kauri, the last minute change, I think Gayatri filled up with some emergency. And the panelist, Dr. Renju Arun, Dr. Kokila, Dr. Uma Brinda, and another one?
Swati ma'am from Melur.
She finished her emergency and she joined back, I think. Anyway, thank you. And the UR speakers, Archana and Ashika. Fantastic work. And as usual, our judge, Dr. Shanti and Kartika Prabhu, thank you so much. And Sakiti for the wonderful work, and Sri Priya for coordinating. Thank you, Ramani Madam. I think she will be on a train. So thank you. I think with the address, definitely the prizes will reach. Now the Sakiti is ready. First is Satya Priya from Salem. And second is Lalita Nair from Chennai. Anyway, congrats. Both of them have mentioned the numbers. So from the shield, the prize will reach you. It's only a small prize to encourage the delegates. Thank you, Radhika. Thank you, all of you.
Thank you,
Good
Sampath
night
ma'am.
and happy Deepam.
Thank you.
Congratulations, Sampath. Sampath, congratulations. Even on Kartiga Day, no?
Ama.
You are very stubborn to conduct the marathon.
Ama.
For that, great congratulations. Okay.
Thank you. Very, very sorry.
Thank you, ma'am.
Radhika,
Thank
you
you,
are
Anjali.
doing your duty very well.
Thank
But
you, ma'am.
it
Sorry,
was not informed that I am a chairperson.